Hi everyone, my name's Aisha. I'm a graduate from the University of Salford and this presentation is based on my master's thesis. I apologise in advance for the obviously bad lighting and potentially bad audio and the structure of this presentation, but hopefully the importance of my research will still come across in the way that I intend it to. The structure of my presentation is as follows. I end the presentation on my own research, how I carried it out, and the future research recommendations on the back of that. So let's get to it. There are around 2.89 million cases of coronavirus with more than 78,000 reported deaths. According to statistics, brain groups are disproportionately affected by the virus in that they are significantly likely to die from a COVID-related death. It's not just the mortality rates that are of concern. The impact the pandemic has had on mental health is crippling. The extended isolation periods, disruption to daily routine, changes in financial situations, and national lockdowns all contribute to the rise in mental health problems. There's an abundance of literature on the disproportionate impact mental health has on BAME groups. This, coupled with the pandemic, only exacerbates the negative outcomes. Social distancing guidelines have pushed telemental health services to the forefront. Telemental health has been found to be effective in the treatment of anxiety, depression, PTSD, schizophrenia, with outcomes comparable to that of in-person treatment. It's relatively inexpensive when compared to the cost of in-person treatment, with reduced costs in travel and flexibility with appointments, which could help in improving attendance. It's especially perfect for those that are high risk at the moment who can't leave their homes, which means that they're still able to get the support that they need. However, it's not without its challenges. There's a lack of validated assessment tools for use in large populations, and it's unclear how well it would work for those with more severe mental illnesses. For example, it may be difficult to adequately detect and monitor symptom presentation, as over video conferencing or over the phone, these behavioural cues can be missed or they may be absent entirely. It also may not be suitable for everyone. So for example, the elderly who are not the most confident in using technology, or simply those people that don't have access to resources such as computers and the internet. Finally, those that live with others may be reluctant to share their troubles or receive counselling whilst they're at home due to a lack of privacy. So despite the challenges that accompany telemental health care, there are benefits to it. So what is culturally appropriate healthcare? So there is no universal definition as to what culturally appropriate care actually is, but this phrase is appropriate as it combines all of the different aspects of life that contribute and can impact mental health and how it presents itself. So why do we need to culturally adapt treatments? Help-seeking behaviours are impacted by stigma surrounding mental health and its treatment. This means that those are in need of treatment are less likely to seek it. Studies demonstrate that these beliefs are often held by many different ethnic minorities. This could be a result of mistrust of service providers as a result of implicit or explicit institutionalised racism. The discrepancy in care could also be a result of socioeconomic status or language barriers. For example, the individual is less likely to receive the help that they need if the health professional is unable to understand the full extent of their symptomology. So does adapting treatment actually help to overcome these issues? Greiner and Smith found in their study that interventions that were targeted to a specific ethnic group were 4 times more effective than when they were delivered to a diverse group. Not only this, but when delivered in their native language, the intervention was found to be twice as effective. Similarly, Benish and colleagues found that producing an image of how the individual perceives and understands their illness is heavily influenced by sociocultural environments, which could be consistent with their cultural background. Therefore, it's important to take into account the cultural background, as this can saliently shape the expression of mental illness. We know culturally adapting treatment works, as research on culturally adapted CBT depicts. There is, however, little research on culturally appropriate telemental health care and its delivery. So in order to understand the research that is out there at the moment around culturally adapted telemental health services, I found 2 papers, only 2, that explore the effectiveness of it in treating depression in ethnic minorities. The first review, conducted by Dawson and colleagues, found a reduction in depressive symptoms and found general acceptance and satisfactions with using the services. They conclude the reason behind the lack of studies in this area is the difficulty in producing high quality studies. So the outcomes were great, but again, the studies lacked high quality designs. The next review by Hu and colleagues was slightly different. They looked at telemental health as an adjunct to regular treatment in ethnic minorities in the US. Interestingly, they didn't find linguistic tailoring had a significant impact on treatment outcome. Authors concluded that it's unclear as to why adapting treatment provides better outcomes. So it worked, but again, it's unclear as to why it works. It's unclear the extent to which tele-mental health services can improve access to high quality care for ethnic minorities, or how culturally and linguistically appropriate care can be implemented online effectively, or if there's a certain treatment modality that works better than others, for example, video conferencing over the phone. Considering the effect the pandemic has had on racial and ethnic minorities, combined with stigma in society, this is an area in need of exploration. So in efforts to expand knowledge on the effectiveness of culturally adapted tele-mental health services, this review aims to answer the following. So are culturally appropriate tele-mental health services effective across different disorders? What aspects of interventions are adapted to make them culturally appropriate? A search strategy was combined, and the following search terms, as seen in Table 1, were used across a number of different databases. The initial aim of the study was to explore the literature comparing culturally adapted tele-mental health treatments to a non-adaptive tele-mental health treatment. The lack of research in this area prompted me to expand the search criteria to include studies that were conducted on a global level. And there were no restrictions placed on methodological design, the type of mental health disorder, or the intervention. The PRISMA guidelines were used to conduct a thorough search and identification of the articles included in the review, of which were a total of 9 studies, 6 of which used ICBT, 2 used video conferencing, and 1 used a telephone. There was improvement in treatments outcome across the studies identified in all different areas. So all of the participants that partook in these studies had an improvement in their symptoms. A few of the papers translated existing clinically efficacious programs so that they were available in English and in the native language of participants. Adjustments were made so that illustrations and examples were somewhat relatable and familiar to the target group. For example, the loss of identity and familiarity that comes with migrating. One study found that recognizing the importance that religion plays in their participant role helped them to encourage participants with their treatment adherence. So, for example, mentioning quotes from religious books. Adapting programs like this is effective. However, it's still unclear as to why this works. Is it the modifications that are being made, or is it the therapy itself? For example, in the study conducted by Kay Roos and colleagues, the authors utilised the wellbeing course, which was developed for the general Australian population. With minor modifications, such as translating keywords and changing examples, the treatment outcome was positive, so it worked. The researchers pointed out that they did not aim to see if the modifications were necessary and if the same results could have been obtained using the original program. Telemental healthcare has the potential to overcome the barriers preventing help seeking. Participants reported that anonymity was a major factor in seeking help. There were, however, high dropout rates, which suggests that there are individual characteristics here at play that impact treatment adherence. Now into the limitations of the studies that were included in this review. So 3 of the 9 studies were pilot studies, providing preliminary study results, which means that any conclusions need to be taken with some caution. Due to the lack of control groups, it's difficult to determine the long-term effects of treatments. Alongside a lack of follow-ups for the control conditions, some of the studies also failed to use an active treatment condition. So true comparisons of treatment are limited. Another issue is around generalizability. Sample sizes were relatively small. As the studies were conducted in specific ethnic groups, it's difficult to know if the same techniques would work for a different ethnic group. This again could be due to the fact of us not knowing the underlying mechanism of why adapting treatments does work. There are also more female participants compared to male participants, suggesting that females are more likely to seek help than males, which is a common pattern throughout mental health literature. Lastly, the lack of structured clinical interviews to confirm a diagnosis prior to treatment is another issue. Majority of the studies relied upon self-report, which, as we know, can be unreliable. However, all of the researchers acknowledge this and put it down to a lack of resources and participant conditions, for example, wanting to stay anonymous. Overall, this limits the ability to evaluate clinical efficacy. So to conclude, the results demonstrate improvement across all studies reflective of previous research. So culturally adapted tele-mental health services are effective. However, because of a lack of high quality studies, it's difficult to confirm the long-term effects of treatment and how they compare against in-person treatment. This research is especially important due to the increased demand in online mental health services as a result of coronavirus. So future research recommendations. An ideal starting point would be around a universal definition for what culturally appropriate care actually stands for and what it means. This would help to produce studies that can lead to effective treatments, as it sets sort of like a baseline. As the healthcare system is different in the UK and the population is so diverse, it is vital that research is conducted in this country. And it'd be interesting to see how the culturally appropriate interventions would work with our current healthcare system. And these services could potentially be disseminated into routine care. Higher quality studies are needed with larger sample sizes in order to make judgments around clinical efficacy and how effective they really are. It's also important to work out the underlying mechanism of the adaptive treatments. Why do the adaptive treatments work better? The pandemic has led to a shift in the way treatment is delivered. Tele-mental healthcare has great potential, but more research is required before it becomes implemented and is available to work across populations and different ethnicities, as they're the ones that are in need of it most of all right now. Thank you for listening. Thank you for watching.